search on every single day. I'm like,
All right, we're gonna get started.
Hi there, midnight.
So last week we talked about the heart in the electrical sense, and this week we're gonna talk about the anatomical sense, right? Like how the pump works and how the circulation works. Before we start with this, I want to remind you that the senior level courses, you can't just cram before the test. You need to be reviewing your content each week. You need to be looking it over and doing the readings and looking at where your study guide outcomes are. To kind of build on this. So this isn't something that you can just kind of memorize real quick, the 2 days before the exam and then pass it. We want you to actually kind of absorb it and kind of ask some questions and think about some things. And when you come to class, say, like, I was looking this over, I watched this video that you posted and I had a question on it, just to try to absorb it so that it works better. There are video links posted in each module. Some of them will watch in class together, some of them watch on your own. And they are for visual learners. They're for a different perspective. There's something that kind of gives you a preview of what we're going to talk about, or maybe a patient experience video, something like that, that kind of connects the dots so that it's not just PowerPoint slides that you're learning from. Okay, you're free to do your own research, but the ones that we post, we kind of vet, and a lot of them are from accredited sources so that we know what you're getting and what you're watching is what we approve of, right? That we think it's of value. It's not like Billy Bob's heart website, right? Also for this Thursday, you saw the announcement. So we're gonna be doing, each group is gonna spend an hour with me and an hour with Kevin, and then we're gonna switch. I apologize, I did not know that many people wanted to be in a morning group. So what I might do is I'll put out a poll for the next one and I'll keep the list. And if you didn't get your first choice this time, maybe I'll make sure you get your first choice next time. So, the reason why we're dividing up is because we want you to do more hands-on things, right? Did you guys like the lab last week with Kevin, where you got to use the monitor, where we did some things? We try to give that feel every week, and it's hard to do that, and a lot of people don't feel comfortable asking questions in a big group, but if you're a group of 8 or 10, you do feel more comfortable, and it's more of a personalized experience, right? As you could do more of the hands-on things. So this Thursday in lab, that's what we're gonna be doing. Next Thursday is gonna be a quiz, okay? If you're someone with accommodations, you need to send me an email. And I will let you know what you need to do for taking the quiz, because I want to make sure you can take it in an environment that's good for you and that you get your extended time if you need it. It only counts as an assignment grade. It doesn't count toward a test grade, and it's a checkpoint for you, right? What type of questions are we going to be asking on the test? Is this information that I know? I think I vaguely remember this, or this sounds completely different. Where did she pull it from? Oh, wait, I better go back in my PowerPoint, my study guide, and see where it is, right? Or better look at the table in the book and see, okay? This week for the study guide, you will notice on the bottom, there are some medications, okay? There is a medication sheet that goes with this course. Did you guys print it off by any chance?
Yes.
Okay. So this sheet is what we will be working through in this course. So you don't have to know it all right now, but on the study guides, I'm gonna highlight which group we need to learn for this week, right? So if you pull it up for this week, it says statins, and it says aspirin, and it says beta blockers, right? So you don't have to memorize everything now, but it should be reviewed. These should be medications you've heard of before, but I really want you to know, like, what does it do? What are the side effects? When do we not give it, right? Because if you have a patient that you're giving their statin to lower their cholesterol, and they're telling you the reason they're not taking it is because they gives you really, really bad muscle pain, right? It's hurts too much at work. I can't use my hands. I can't climb the ladder, whatever it is. We need to know that, yeah, that's a side effect that we might anticipate. What do? Maybe if you take it at night, take it at night, and maybe when it kicks in, you won't be as sore in the morning. Those type of things. So that's what we're gonna do with this. Also, I want to show you the concept map. That I put on here. Or we call it a skills template, right here. For some people, this works extremely well. For other people, they don't really, they have their own way to study, but I want to offer this to you just in case. Okay, so if you're coming across something that maybe you don't know, you don't understand, it's been a minute. Here's something that you can do. You can either do it during class, or you can, when you're going over your notes, you can try it. Okay, so this is also what we want you to do with your clinical paperwork as well. Use this type of thought. So what is my disorder? What is the thing that I'm talking about, right? So maybe I'm talking about like MIs, okay, heart attacks. So that would go in the middle. Then the pathology, what does that mean? Like, what is the definition of a heart attack, right? Today we're gonna figure it out. What are my risk factors, right? If there's a genetic component, this is where I put it, okay? What are my expected findings? What are my symptoms that I want to look for? What goes with MIs? What are the labs? Anything that we need to do medication wise, right? What are some things that might be on that? Dietary activity considerations, treatment goals, education, interventions, potential complications. So I had students last semester who had a notebook full of these by the end, because they would do 2 or 3 or 4 for every exam, and they'd bring them to me during office hours and be like, look at these, am I on the right track? Did I do this right? And something about going through your notes, right? And putting it in the right area, it makes you connect the dots, right? If I'm physically looking at the center and then I'm kind of drawing arrows to each box, it helps kind of give you an overview and pull out the important stuff instead of just rereading your PowerPoints and hoping you're pulling out the right information. So if we do anything that has a pathology, anything that has like an actual diagnosis, right? It's kind of hard with like electrical rhythms because that's kind of a broad topic. But again, if we're doing heart attacks, if we're doing liver failure, if we're doing hematology stuff like sickle cell, this is a really good resource if you don't know where to start, or taking notes, or trying to put it all together. Okay, so that's something that I want to kind of put your attention to. It's under the week 1 module. So you can go back in there and find it if you would like. Okay. Questions on that? Does that sound like something you could do? Maybe, yes, no? Okay. Last week, this didn't record 100%, so I had to do some from my office. I'm hoping this week it records and we are well on our way. All right, so if you look at the amount of slides we have this week, there's a lot, but there's practice questions and there's a lot of pictures in there too to kind of reinforce it. This picture I found and I really, really liked, and I want you to look at it because of the terms that we brought up last week. So in this visual representation, the water coming out of the tap is your venous return. Okay, it's coming back to the heart. So here is your diastole, right? The bottom number on your blood pressure, where it's filling, right? So it's coming back into the heart and the heart is still and it's getting full. Okay, here is your preload. That's how much is in there before your heart contracts. Okay, so that's your end diastolic volume. Then when we get to systole, right, which is your diastolic blood pressure, which is the pressure of squeezing, that narrowing at the top is your afterload. That's what you're squeezing against, right? So narrowing in the bottle, or it's the pressure in the artery. So that is what you're actually is holding it back. The amount that's actually coming out the top then when you squeeze is your stroke volume. And then this very last one, Mr. Tickle's been coming, is your end systolic volume, right? That's what's left, because your heart is never fully empty, or it shouldn't be. This is what's left, and then we go back to the beginning where it fills up again. Okay, so I just thought that was kind of a cool representation. So if sometimes those terms get a little, what's preload, what's an afterload, that kind of gives you a good visual representation. Okay, we're gonna start talking about lipids. We're gonna talk about cholesterol, we're gonna talk about your arteries and your veins and what's in there. Anybody not ever had any experience with the cardiac labs that include lipid profile? Okay, we draw it on an empty stomach because we want to make sure you're fasting, so it's not a representation of the pizza you just ate. We have the total cholesterol, we have our high density lipoproteins, which are the good kind. We have our low density lipoproteins, which are the bad kind. We also have a ratio, right? So that used to be something that was really popular and you'll still see it. We have our overall cholesterol. Once you take out the good stuff, what's left, which is our non-HDL. And then we have our triglycerides, which are actually fat in the blood that then becomes reabsorbed. So we use it for fast fuel, and what we don't use then it gets stored as fat, and that increases our risk of heart disease. Okay, optimally, these are the numbers that we want you to have. Okay, this is what we want them to look like. Not necessarily are these going to look the same for whatever lab you use, whatever resource you look online, but we're all just going to agree that this is what we're going to go with. Okay, that's not everybody's going to be off just by a little bit. So less than 100 or less than 200 for our total cholesterol. We want our good cholesterol above 40, our bad below 100, and we want our triglycerides less than 150. So higher than that, we know we have an increased risk for heart issues. Okay. When we're looking at the heart, okay, there's lots of vasculature. If someone says they have a quintuple bypass, bypass, these are the 5 that you can bypass. Okay, you have your coronary arteries, your circumflex, the main one right here, that left anterior descending, that's the one we call our widowmaker if it gets occluded. That's because it goes to your left ventricle. That's our main pump, right? So you have an interruption of blood flow, that main pump, and you have a bad day. But all 5 of these, when someone tells you they've had triple bypass, double bypass, quadruple bypass, these are the ones that we're looking at. Okay, just as a frame of reference. So we know that the blood flow to the body is managed by the heart, but you have to remember that the heart is a muscle and it's being fed to. Okay, so that's something we have to keep in the back of our mind. So we know that our blood flow is regulated by what's going on in our arteries, right? How much the heart is able to pump, how much they're pumping against with the constriction, and our collateral flow, right? We had 5 main arteries, but there's lots of other blood vessels that come off of there. That's our collateral circulation. Okay, all of this is what feeds the heart. The main reason we don't get blood to the heart is atherosclerosis. Okay, anybody not familiar with this topic? Hopefully you remember what that is. And that is a progressive disease. Okay, that is where those cholesterol or those lipoproteins and fibers kind of can collapse inside and thicken and narrow the blood flow. We call it plaque. Okay, because as those cholesterol molecules and all those fats kind of join together, it makes a hardened surface. Okay, and that also goes, it doesn't necessarily go in the flow of traffic, but it goes in the walls of the artery as well. Okay, and that's what makes it narrow. I forgot to copy this one. So I'm going to show you what I mean by that. Maybe. You can ignore the sample you saw.
Atherosclerosis is a life-threatening disease that may have begun to develop during childhood. This condition is a process in which deposits of fatty material, called plaque, build up inside the walls of arteries, reducing or completely blocking blood flow. Although the exact causes of atherosclerosis are not clear, many scientists think it begins with damage to the inner wall of an artery, called the endothelium. Substances traveling in the blood, such as cholesterol, fats, and cellular waste products, accumulate inside the damaged area of the arterial wall. Chemical reactions occurring within the buildup of material cause cholesterol molecules to oxidize. This initiates an inflammatory response in which the endothelial cells at the damaged site release chemicals that signal a call for help. In response, monocytes from the bloodstream travel to the damaged site. Stimulation from oxidized cholesterol converts the monocytes into macrophages. The macrophages eat and digest the cholesterol molecules. As a result of this process, the macrophages change into foam cells, which accumulate to form plaque. As the plaque increases in size, the arterial wall thickens and hardens. At the same time, smooth muscle cells within the arterial wall begin to multiply. Most of the smooth muscle cells move to the surface of the plaque. These cells contribute to the formation of a firm, fibrous cap covering the plaque. Eventually, the passageway through the artery narrows enough to reduce blood flow and the amount of oxygen received by the organs it supplies. Over time, the cap may erode and break open, releasing plaque into the bloodstream. The plaque can flow downstream and contribute to the formation of a blood clot, which can stop blood flow. As a result, limited blood supply is available to the areas surrounding the partially blocked artery, degrading and potentially killing the neighboring tissue.
Okay, does that make it look a little bit more? The sound effects. So when we talk about atherosclerosis, right, I think we all hear about heart disease and we all hear about like how narrow the arteries, but seeing it from that aspect, right? So there's a lot of research being done right now that actually says that diabetes is more of a problem for atherosclerosis than the high cholesterol is. Because when you have diabetes, right, we know that we have poor circulation and it damages the lining of our vessels. So if they're more susceptible to injury, then you have more of an area where those fats and everything are gonna get in there to cause atherosclerosis. So lots of things that are tied together. But that's what we're looking at, are those narrow. So once someone gets diagnosed with that atherosclerosis, then we actually call it coronary heart disease, right? You might hear coronary artery disease, but we're gonna also talk about coronary heart disease as the umbrella, okay? When that happens, we have less blood getting to our heart itself, and we know that it can progress to other things. Most people that have atherosclerosis have no idea until, right, they start to have one of these things, the angina, the acute coronary syndrome, they have something going on. But they have actually done studies and they have found plaque buildup in atherosclerosis in kids. Right, so kids eat a steady diet of McDonald's and inactivity, all the things that we have, they can get it too, so it's not age related, okay? In your book, there's a table where it talks about all the different risk factors. I think we know a lot of these, but here's just a quick refresher. We know men have more problems earlier, women over 55, but once they hit menopause, the risk is the same as men. We know that based on your family history, if you've had somebody with a cardiac event or coronary heart disease in an early age, then you're at great risk of it. Familial hypocholesterolemia. This is near and dear to my heart because my husband has it and my 13 now, 13-year-old son has it. My husband ended up with 2 MIs. One was a silent MI, he didn't know. The doctor told him you're too young for heart disease, it's probably a pulled muscle. And he actually had a pretty massive heart attack to the backside of his heart. And then he had another heart attack at 37 and had triple bypass. So because of that, we found out he had this genetic condition. My kids got tested, my son has it. And quite a few of my husband's relatives have it. Once he had the heart attack, they all got checked. And he had a 25-year-old cousin who had a cholesterol of 525. So what happens is your body just doesn't metabolize the LDL, which is the bad cholesterol, and then that makes things worse. So that's what you can't change. What you can change is you can control your diabetes, your high blood pressure. You can keep an eye on your lipids, right? You have high LDL, we want to get it down. You have low HDL, we want to get it up. We know stress is a huge factor, smoking, obesity, right? Eating things high in hydrogenated oils. There was that big push in the media, get rid of trans fats years ago, right? Women, use of hormone replacement therapy, right? It can make it a risk factor that maybe you can modify. And anything that's inflammatory, right? Anything you do that helps. Is that somebody's phone or am I hearing things? Oh, okay, all right. Maybe I was hearing things. You know how they say when you have a stroke, you smell things that aren't there? That maybe I was hearing something that wasn't there. So how do we know? How do you know you have atherosclerosis or the beginning of coronary heart disease? You got your blood drawn, right? If we look at that lipid level. C-reactive protein, that's a lab that checks your inflammation. All these different tests you can do. Your ABI, right? A stress test. We've all heard of stress tests where you walk on the treadmill and you see what your heart does when it's under stress. We can do a calcium scoring test. You'll see ads from different hospital systems. They offer free calcium CAT scans, right? And it looks at the calcified plaque in your artery and it gives you a score, lets you know if you're at risk. They can do some type of perfusion imaging, which we sometimes call a cardiolite stress or nuclear stress, where you walk on a treadmill, but you also get imaging done. Okay. With this one here, this cardiolite stress or the nuclear stress, if for some reason you are not able to walk on the treadmill, mobility issues, something like that, they can give one of these medications and it will actually mimic the heart stress. And it'll accelerate your heart rate even though you're laying down. And we can do it that way. So mobility is not a barrier to getting a heart test. Okay. So when you look at a cardiac stress test, what are you looking for? How do you know? We talked about the electrical system last time. So how do we know when you're exercising what it looks like when your heart is under stress? Okay. So we talked about this blue line. We talked about that being the isoelectric line, right? You want everything to come back to that line. We have the P wave, the QRS, and into the T. Where it slopes down here, right? We call that the J point. That's not important, but that's the starting point where we know at the J point, you should be back to that line. And when it's not, that lets us know there's a problem. So if there is a change, right, of more than one box, which is how much in time, do you remember? 0.04, yeah. If there's a change of one box, then we know that the heart is under stress. We call that ST depression or downward sloping. So if we look at what your heart rate looks like from an electrical standpoint without stress, and then we hook you up to the treadmill and we make you walk at an incline and we start to see this kind of stuff happening, that's not good, right? That lets us know something's happening. That's before we even get to a blockage. That just says that there's enough issue in the heart that we see a slowing down of the conduction. Okay. Do you want me to show you the video of the stress test or you got it? Gonna see the video? Yes, no? No? Okay, all right. So what do you do if you're diagnosed with atherosclerosis or coronary heart disease? There are things that we need you to know. If it has this yellow asterisk, that is on that cardiac medication sheet. Okay, so that's where you can get some information, but these are the ones that are mentioned in your book, but the ones with yellow are the ones you really need to know. Statins, torvastatin, simvastatin, pravastatin, all of those. What that does is it inhibits your body producing cholesterol and triglycerides, right? People don't like to take them because they make your joints and muscles sore, but these are kind of our gold standard. They've been around a really long time. Okay, bile acid sequestrates. Okay, those reduce your bad cholesterol from being absorbed in the stomach. Nicotinic acid is something that we use. Also niacin. If anyone's ever seen the supplement niacin. funny story about niacin, it causes vasodilation, right? That's what it does. And there's a big push, it kind of cycles around, I'm sure it's on TikTok somewhere, where you take niacin if you have heart issues and it helps improve blood flow. If people aren't careful and they don't take the super slow releasing niacin, you will dilate all your blood vessels at the same time. You will feel like your skin is on fire, like you have pinpricks all over you and you sweat profusely. So I used to laugh when I was working in the ER, and every once in a while you get a guy who came in, his wife dragging him in. Oh my gosh, I think he's having a stroke or heart attack. Look, he's all red and he says he's on fire. And I would kind of giggle a little bit on the inside. I'm like, did you by any chance give him niacin? I did. I'm like, yep, that's okay. You're gonna be fine. It just takes a little bit for it to go away. So if you ever have anybody come in and they are saying they tried niacin for the first time and they feel like they're on fire, just remind them they're not gonna die, but that it worked a little too well. So that's a supplement. So again, when we ask people what they're taking, make sure you ask what your supplements are, because sometimes they're just as important as the medicines. Okay, fibrates. Okay, phenylfibrate, you'll see a lot of patients that are on this. It lowers the production of your fatty acids and your triglycerides. And then our antiplatelets, right? These don't do anything with your cholesterol, but we know our aspirin, our Plavix keeps those platelets from sticking together. And if we already have a bump, an occlusion in that artery, anything that sticks to it is gonna make that obstruction bigger. So those antiplatelets help keep the blood moving and help them keep from sticking to the side. Okay? Statins, everybody should understand because they are one of the most prescribed medications you will ever see, right? They have a list of 200 of the most prescribed and that one's on it, which tells you how widespread heart disease is. And I love this picture because one of these things is not like the others. So we talk about statins. Remember, nystatin we use for yeast, right? All the other statins we use for the heart. So just keep that in mind. Not all statins are like. Okay. We also need to do a good job of considering what's going on as far as what their lifestyle is. Do they know about their risk factors? Do they know they should get some blood work? And we want to make sure that we do what we can to keep them compliant with whatever therapy they're on. Okay. So here's a question. If you're looking at lab results, which one would tell you they have a risk of heart disease? Okay. And SATA stands for select all of the blood, in case you wondered. Okay, if you have an answer, give me a thumb up, so I know we can move on. Okay, so which ones are high? A and C. So A, cholesterol over 245 and an LDL over 100, right? An HDL of 90, is that good? We want it above 40, okay? And triglycerides, we want them over 150 is it's a risk, okay? So that one had them listed at 125 and a ratio, that's where we want it to be. We want it to be below 4.9. Okay, so what happens if we have the atherosclerosis and we have the coronary heart disease? Okay, so here's where things start to get a little more in depth. It can cause ischemia, right? And basically that means that the heart muscle itself is not getting enough blood to feed it. Okay, so when that happens, we don't have enough oxygen, right, to get to the heart muscle so it works like it's supposed to. All right, so what causes that? Some type of an obstruction, some type of spasm that temporarily clamps down, a blood clot, or something that's causing your blood pressure to drop, right? If you're in shock, or maybe we do something, have a reaction to something. So whatever happens, you don't get enough oxygen and the heart muscle itself starts to have some issues. We call that ischemia, okay? So what happens if you want to like follow it all the way through is that when you don't have oxygen, right? Anaerobic metabolism is when you metabolize things without oxygen, right? So that starts to happen. We start to get lactic acid that builds up. That lets the heart know that there's something happening and it starts to send out this enzyme into the bloodstream, which then is translated to pain, right? Because those enzymes hit nerve endings. And then we start to have some complications. We start to feel it, okay? If for some reason, whatever's causing the blockage is taken care of, then it's fine, it goes away. If it lasts more than 30 minutes, then we have ischemia that goes into progressive damage, permanent damage to the muscle. Okay, so if it's less than 30 minutes, ischemia can be resolved, it's no big deal. If it lasts more than 30 minutes, we've got our permanent damage and we can't come back from that. You look in your book, it has a whole list of things that contribute to ischemia, right? I won't bore you with details, but there's a whole lot of them. So your heart has issues with getting blood and it's not being perfused. It doesn't have the oxygen that it needs, right? So again, here's our normal. We call that ST depression. You can see where that scoops down below that isoelectric line, okay? That lets us know that's the heart's way of telling you that it's under stress. Okay, so anytime you see ST depression, the T wave may be flat, right? Or it may be flipped upside down. Okay, so it's one or the other. In your book, it gives you some examples of that as well. So here's where we have to decide where we're going down this pathway, right? We have a heart that's starved of oxygen. We can go off to the left, right? And we see ischemia with blood flow decrease, and we have this area that's hypoxic, right? But that can stay on this side of the table. If for some reason we have the blood flow is cut off, not decreased, but it's cut off, and we have cell death, then we have a much larger area and a much faster damage. Okay, so ischemia is going to be our pain and our temporary imbalance of oxygen where it's interrupted, and our infarction is going to be it is completely blocked. Okay, so again, here we go. I want you to understand the difference. Okay, so heart disease is our umbrella, caused by mostly atherosclerosis. Okay, so we can come down in two pathways here. We can have ischemic disease, or we can have acute coronary syndrome. Okay, it kind of comes down into two different causes. Your book calls myocardial infarction its own topic. And if you're reading your book, we have acute coronary syndrome, and it's going to mention a few things, and it's going to say, yep, MI kind of falls under here, but we're going to cover it in depth in a couple pages. But it is still part of acute coronary syndrome. Okay, a chronic ischemic disease. We're going to talk about angina. We're going to talk about different types of that. But we have two types that are pretty stable, pretty chronic. We know that they're there. We have one type over here that falls under that acute coronary syndrome. Okay, so I just want you to keep that picture up. Here's our umbrella of heart disease. There's two different branches off of that so that it makes sense. Okay, because angina basically means chest pain. Okay, so when anybody gets pain, okay, it comes on with activity, but when I sit down, it goes away. Remember, it's not an infarction. It's not permanent damage. It doesn't last more than 30 minutes, but it can be a squeezing, a pressure, a heaviness. It can radiate, go up in the jaw, wherever. But when I sit down and I take the stress off my heart, it goes away, right? It's a temporary obstruction in my heart, temporary reduction in blood flow, okay? Sometimes they don't get that crushing chest pain or they don't get anything like that, but they start to feel real short of breath, right? Or they start to get tachycardia. Because if the heart's not getting blood, you think that the electrical system also is affected? Yeah, it is. So you can start to get some extra beats and feel strange. In women and diabetics, they're not going to present with a typical, it hurts here, radiates down my arm. A lot of times their symptom is simply, I feel super tired. And I don't know why. Okay, I have indigestion, very vague symptoms. I had a patient who came in and their symptom was I burped too much. That was their symptom, and they were having major heart issues. So it doesn't have to be, we used to say that it was a certain presentation. Now it's like between your neck and your navel. If it's a woman or a diabetic, if there's something abnormal, think heart. Okay. Here's what our angina, depending, you'll hear it two different ways, looks like. Here's our regular artery, right? Nice and clean, nothing wrong with it. here is our stable angina. That means that we know we have a blockage, we know it's there. We know that when I do activity, it's gonna interrupt the blood flow, but when I stop, the blood flow is gonna be back where it was, okay? And so this is the most predictable, it's the most common, it's exertional, right? When I stop moving, it gets better. Down here is our variant, or our Prince medal, and that is where there's really no blockage, but everything spasms, right? It constricts, and that narrows the blood flow. It does not have to be related to activity, but it's something we know is there, it comes and goes, and we can treat it. Here's where it gets to be problematic, which is our unstable angina, right? Which is technically our acute coronary syndrome. Okay, and this is where you have something that's already present, but those platelets stick together, where a little piece of plaque comes in, it doesn't cut off the blood flow, but it really super narrows it. Okay, and this can happen anytime. It doesn't have to be with activity. It can wake you up in the middle of the night. If you stop doing whatever you're doing, doesn't necessarily go away. Okay, so unstable angina, right, is part of acute coronary syndrome. And that's where we're really getting concerned, because if you only have this much space to get blood flow to that heart muscle, right, you are at a big risk of having an MI, because all it takes is one more little clump here and you completely block the blood flow to the heart. Okay, so these two stable, treatable. This one, we really are concerned. Okay. So when you have the stable kind, right, we know that they have coronary heart disease. We know it's there. We know it happens when they're moving or they're under stress. So what do we do for it? We know that we give nitro, right? Nitroglycerin. And how do we typically tell people to take nitroglycerin? Under your tongue, right? You spray it, or you pop the little tab. When you put the tab underneath, it's gonna pop and it's gonna burn and it's gonna taste gross, right? And then what happens? What do they complain about right away? A headache, because it's gonna open up all those blood vessels. It's a vasodilator. So we get the blood to the heart, but it also goes to the head, and they complain of a crushing headache, right? That's what we want to happen. Unfortunately, it's a side effect, but rest and opening up those blood vessels is how we're gonna treat it. And then if we know that you have this, we're gonna give you something to help. Okay, so you've got your Resco Nitro, that's our #1 med that's gonna make it better, but we're also gonna give you some long-acting nitro, right? We call it nitrate. We're gonna give you a beta blocker to keep your heart rate low and keep everything dilated. We're gonna give you some calcium channel blockers, but our go-to for a stable angina is rest and nitro. Circle it, highlight it, star it, whatever you need to do. Okay, for the other kind that is pretty stable, meaning that we know what it is and we know it's not really a risk for an MI, we've got the variant, right? We've got the spasm. Right, so you could have a blockage from some plaque, or it could just be a vasoconstriction, right? It a lot of times happens at night, don't know why, right? Has something to do with your circadian rhythm. But again, when that happens, we're gonna tell you to rest. If we're already resting, that's fine. We're gonna give you that nitro. It's gonna open up that blood vessel, give you the bad headache, but then that's how we're gonna take care of it, right? So there's a fix for those two types. All right. For our unstable, this is the beginning of our acute coronary syndrome. It says acute, we know is a problem. This could be just sitting here in class, you're gonna feel it, okay? And we tried the rest and we tried the nitro, because that's what you do with angina, right? And then it's still there, okay? It does not mean you're having a heart attack right now, but it means that we really need to pay attention. This is an emergency. Okay, because you could just be doing nothing and it's gonna work. So it's different in the chest pain. This is more severe. It's gonna last a little bit longer, and these attacks can happen more frequently. Right? You might have it one time, lasts for about 20 minutes and it goes away, right? And nothing happens. But then the next day, and then maybe it's twice a day. And what your body is telling you is like, this artery is getting really not good at delivering what it needs to, and we need to get it looked at. Okay, so one last kind that sometimes we don't really think about is we can have a silent ischemia where it's happening and you don't even know it. right? And what's happening is your heart muscle is being stressed and not getting good oxygen, but maybe you're not having the major symptoms. And a lot of times we don't realize you're at risk of MI, right? Because you're not feeling that. So that can happen even if you're not aware of it. Okay, so nitrates, nitroglycerin under the tongue takes about a minute or two to kick in. It decreases your preload and afterload, right? It allows everything to fill, everything to dilate. You can take 3 doses, 5 minutes apart, right? Take one, wait 5 minutes. Take another one, wait 5 minutes. You can do that 3 times. And at the end of 15 minutes and 3 doses, if it's not any better, then you're headed to the ER. But if you have this condition, right, people keep their bottles with them all the time. Then you can have a pretty good quality of life while you're waiting on, whatever else is happening. Beta blockers are meds that end in LOL, right, are LOLs. If it's stable, right, we have this nitro for a rescue med, but we have beta blockers, right? We keep everything low and slow, low heart rate. We want to keep it nice and low. We want to keep everything nice and opened up, okay? And so what that does is keeps our heart rate down, which then makes our heart need less oxygen, right? So that it can work a little better and it can pump a little faster. I had a patient, oh my gosh, this was a funny story. I was at the ER and I was sitting at the triage desk and somebody ran in and said, we need help, right? People always need help. So I go out and there's a tour bus that was sitting in the driveway. And I was like, okay, they said there's somebody on there that needs help. I'm like, okay. So we walk on and it's a bus of 70 and 80-year-old people that are going to the Cleveland Symphony, right? And they're all dressed up in their little outfits and they've got their little purses on their lap. And no one's looking concerned. No one's waving and saying we need help. But as we're scanning faces, there is a blue man, right, leaning against the window. And no one else seemed real concerned, which, did you know there's not emergency exits on tour buses? Think about it. There's no exit. So we go in, find some people that are pretty hefty, and we end up kind of crowd surfing this guy down the middle of the aisle because he clearly is not in good condition. And the bus driver looked at me and said, oh, well, he said his heart was hurting, so I gave him one of my nitro. Should I not have done that? I said, probably not. Probably shouldn't have. But what happened was he was having a heart attack. They gave him a nitro and it was a part of the heart that we needed those blood vessels to stay constricted because that was the only thing perfusing it. So she gave him a nitro. It opened everything up. He lost all his preload and all his afterload and he coded. So make sure you don't share meds. That's the moral of the story. He was fine. He did make it, but he took him off the bus and he took off and the poor wife was like, where am I? We said, you're in Ohio. Welcome. Another medication we can use is calcium channel blockers. Those usually end in the word keen. Okay, and those do the same thing. They decrease the O2 demand. So that what you have is readily available. And then we have our antiplatelet, our aspirin. Okay, this is really important for people that have, especially the unstable angina, where we know that it already is narrowed and we know we have a tendency for everything to stick to that. Okay, but those are the medicines we need to keep a look at. In your book on table 30.B, there's a whole list of them. And it gives nursing considerations when to give them all that stuff. Okay, so how do you know? How do you know if your heart condition has progressed from coronary heart disease to something like stable angina? Okay, so we're going to do an echocardiogram, which is an ultrasound of the heart. We're also going to do a transesophageal echocardiogram, a TEE is what we call it, and that's where you do an ultrasound, but you also put a scope down the esophagus. So you're looking at the back side of the heart through the scope and the ultrasound at the same time, so you can get a good picture of the heart. This is also a time to do some radionuclide testing. Okay, and that's where you inject an isotope and you sit them through the scanner, and anywhere that you have circulation, it's going to kind of glow, right? And anywhere that doesn't, we're going to call it a cold spot, where you're going to see where it lights up all the way around it, but you're going to have a spot in the middle that doesn't. Okay. Anytime we're doing any type of heart testing, we wanna make sure that you're not doing anything with caffeine or smoking beforehand.
This might be a silly question, but are you talking about our fundamentals book or our med surg book when you refer to the book in these slides?
That is your Lamone and Burke med surg book.
Thank you.
Yes. Yeah, you won't need your fundamentals book for this course unless you wanna go back and revisit something. So never will I reference your fundamentals book. Okay? That's not a dumb question. Okay, also, a lot of these tests overlap. So go back and look at your other slide for the atherosclerosis as well, because it all kind of tells the same thing. But these are some extra that we can do for that. Okay, a cardiac cath. Who has heard of a cardiac cath before? Okay, that's our gold standard, right? Stress tests are great. They can give us some indication, but I know people who have passed a stress test and who have dropped dead the next day. Right, because it can't be 100% definitive, right, except going in and injecting dye and looking at a heart, that's gonna tell you where the narrowing is, right? If your heart is compensating, you can do really well on a treadmill until you don't, right? I live with a guy who's proof of that. We were doing our roof a couple months before my husband had his second heart attack. Okay, when you do a heart cath, you wanna make sure they don't have an iodine allergy, and here's the gold number where we're gonna look at some intervention. 70% of that artery being clogged, right? That's when you're gonna that's our cutoff of usually their symptoms are starting. Okay, if it's under 50, you're probably not gonna notice it, but at 70, think about that, only 30% of your blood is getting where it needs to go. That's pretty small. Okay. So you can do a heart cath, and I want to talk about this for a hot minute because this is what you're gonna have a lot of your patients do when you're on the floor and when you're on 4 north or 3 north, or maybe on 2 southwest, they're gonna go for a heart cath and come back, right? So I want you to know what to expect with them. We used to do them through the groin only. That was kind of where we started, and the groin is a really good access point. We can thread the catheter up into the heart, but it's kind of a dirty site. It's in a weird spot and you gotta hold pressure because it's a risk of bleeding, right? So what we have found is that you can go through the radial artery, okay? And how they know that they can do the radial arteries, they actually do a test. So you have 2 arteries going through your wrist, right? You have a radial artery and an ulnar artery. So they will occlude the radial artery and they will have you bend your hand and flex it. And if your hand stays pink, then they know that the ulnar artery is healthy enough to perfuse your hand and to maintain circulation, so they can go ahead and use this artery. Okay, if for some reason when they try to do it, it doesn't work, then they have to go through the groin. They have to go through the femoral. Also, if you've ever had open heart surgery, because they've rewired all of your circulation, you have to go through the groin. Okay, but we're seeing more and more going through the radial artery is the way to go. And so your patients will come back with this on. It's called a TR band. Okay, and it looks like a plastic bracelet that has little like bubble wrap bubbles in it. Okay, and so there's a little device on the end here, and it's just like the end of an ET tube or anything else that has a lower lock syringe. They will inflate it. You'll see they'll put the air in there. And then every 15 minutes, half hour, whatever your facility protocol is, you will remove an amount of air. So you will slowly take the pressure off. And so it decreases the risk of bleeding. If they have a femoral site, you are gonna have to hold pressure for a certain amount of time, and they put a sandbag on for a certain amount of time to hold pressure. So this is much more comfortable for the patient. They can actually be upright as long as that they're kind of making sure that that wrist stays stable. They can be much more awake and alert and don't have to lay flat for 4 hours. Okay. Has anybody seen a radial cardiac cath yet? Yeah, it's way better than what it used to be, that's for sure. Any questions so far? Am I going too fast?
64-year-old Richard Caswell is watching his grandson Ethan, number 12, play basketball. Caswell enjoys a close game and cheers for his grandson's team. He's just glad to be here after battling heart disease since 1994.
I've got 13 grandchildren and 3 great-grandchildren. I want to be around for a few more.
Caswell and his wife Jeannie, who has chronic lung disease, have been through a lot. He's had quadruple bypass surgery and 3 heart catheterizations. But his last heart cath procedure was by far the easiest.
I would recommend the procedure in the arm. You're not confined. You can get up out of bed if you want, but if you're doing the one through the groin, you gotta lay there, like I said, for 24 hours.
Caswell's cardiologist, Ibrahim Faza, says 70% of the heart catheterizations he does today are through the transradial artery in the wrist. He says it's easier to access than the femoral artery in the groin, especially if the patient is overweight. And when the procedure is done through the wrist, it's easier to stop the bleeding. The procedure through the groin requires heavy pressure over the incision when the catheter is removed, and the patient must lie flat on their back for several hours, perhaps even overnight.
There is a lot lower risk of complications such as the bruise and the groin hematoma, and even patients can get off their table right away as soon as it's done with the procedure.
And Dr. Faza says the transradial procedure doesn't necessarily mean an overnight stay in the hospital.
You come as outpatient, get your catheterization and possible angioplasty through your right wrist or radial artery. And if everything goes well, you stay in the hospital for 2 to 4 hours, and then you go home and sleep in your own bed.
And for Caswell, less time in the hospital means more time doing what he wants to do.
So prior to using this, they did a lot of groin femoral cardiac casts. So that would tie up nurses for several hours because they would have to actually stand there and they would have to take turns holding pressure, right? So you couldn't move them off of the bed for very long. You would have to stay there and hold it in the actual procedure room, which would slow down how many people you could do. And when you did slide them over, it would tie up one person to monitor that bleeding. It's still, you'll still see it done. So there's some people that have the LNAs that are used, the arteries, but definitely a example of how technology has definitely made it better and easier. If you're going to get in and get out the same day, people are much more likely to make the scheduled appointment. Okay. This is something called the heart score. And when we're looking at how to determine who is at risk, who needs to get the cardiac cath, who needs to do these things, if they come in, this is what we use. Okay, so you're assigned points based on all of these different things. So if you have a history, if you go down here, it's talking about risk factors and history. So if you're a diabetic, if you're a smoker, you have high blood pressure, any of these things. So based on how the symptoms started, right? If you're suspicious, you get points. Based on what your EKG looks like, right? We talked about the ST depression, which shows that you've got some ischemia happening. Based on your age, based on your risk factors, and then based on your troponin limit, which we'll talk about that in a little bit, it's based on your lab work. So we call that a risk of MACE, which is a major adverse cardiac event. So even if you have a patient who seems fine when you are taking care of them, and you go back in later and they're complaining of some chest discomfort, they may ask, you call the physician, they may ask what their heart score is. Right, and that's what they're talking about is what is the likelihood? It is not 100% definitive, right? Because if you are under 45 years old, and you don't have any history, right? Maybe you're somebody who's never been to the doctor. You don't know what your blood work is. You don't know if you have hypertension. So this is just kind of a guide to go off of. It's not by any means definitive, but just to kind of give you an idea. Okay. Questions before we get into the break on the first part? So I got your guys, you're okay. Couple thumbs up and some people look like they're sleeping with their eyes open. Okay, all right, take 10 minutes.
Your toes like alfalfa.
All right, so we are going to move on to the next part. Okay, so if you remember that slide that had coronary heart disease at the top, and then it had chronic ischemia with angina, and then on this side is acute coronary syndrome, that is what we're gonna talk about now. It's acute coronary syndrome, okay? If you have your ACLS book, not on you, but when you look at it, you're gonna see a lot of information, including an algorithm for what to do for acute coronary syndrome. Okay, that's what we're gonna work on tomorrow when we're in lab with me. So what this means is unstable ischemia. Ischemia is lack of blood flow, so unstable, lack of blood flow that suddenly, severely reduces or occludes the heart muscle. Okay, so when you read your book, because I know you're all gonna read your book, like I said, it mentions that MI is part of coronary syndrome. But it puts another part of the book. I don't want you to get confused because it is part of it. So this is severe chest pain, right? Due to the cells being injured from lack of oxygen. It can happen at rest. It is very severe and prolonged, meaning it lasts a long time, and nitroglycerin does not relieve it. Okay, mainly caused by when we've got one of those plaques like we watched in the movie, that cap that covered the plaque and kept it in there, burst open and pieces of plaque fly out. They mix with blood, with little blood clots, or it's caused by a spasm that won't release. Okay, because the word here is prolonged, meaning it lasts a long time.
So could a spasm be caused by low potassium? Like, I'm trying to figure out what's causing the spasm.
So it could be by potassium, it could be drug induced,
Okay.
it could be an anatomy. It could be like the way there's a kink or a bend in something where the pressure increases and it causes it to spasm. Okay, you're in like a really bad spot. You can't really see it all, can you? Yeah. Okay, so I feel like you're constantly like just on the edge. You were standing. Oh, sorry, in front of it. I'm sorry. Yeah, you're fine. Okay. All right, so this slide, please star it or circle it or something. So that you understand the difference between chronic ischemia that we know about, that goes away with nitrogen and rest, and acute coronary syndrome that does not. Okay? All right, so what is included in our acute coronary syndrome? Okay? Our unstable angina, what we call a STEMI, and what we call a non-STEMI. Okay? So the unstable, remember, this is where it ruptures and we have really severely reduced flow, right? When it comes to a non-STEMI, right? This is where there is extensive damage, right? Especially on exertion. And then we have our STEMI. This is what we think of when we watch TV, Grey's Anatomy, and what we see in ER, where all of a sudden we have lots of narrowing, we have something going on, but this STEMI, right, an ST elevation myocardial infarction is where the blood flow is cut off. Right, that's the difference. So all three of these things fall under the umbrella of acute coronary syndrome. This is lab. You don't have to memorize all of this, but I like the visual of it. So first thing we're gonna do is when we're looking at diagnostics is we have to understand what a troponin is, right? Who's heard the word troponin? Okay, perfect. We know that a troponin is a specific enzyme that is released when heart muscle is damaged, okay? It's specific to the heart. It shows up between 2 and 4 hours and it peaks over 36, okay? It stays in your blood for up to 2 weeks, but it is an evolution, okay? If you see this little downward slope here, okay? Troponin is the main thing that we're gonna focus on, and the main thing you're gonna hear are stereotroponins, right? Cardiac levels. Another one we're gonna talk about is CPK, which is injury to muscle cells, generically muscle cells. So we use this, right? Because the heart is a muscle, but it's not as indicative, right? It peaks in 12 to 24 hours, so it peaks a little sooner than the troponin. It's there for a week, but it is non-specific. It's good to know, and it can tell you, right? Like all succulents are cacti, but not all cacti are succulents kind of thing, okay? Then we have a CKMB, and this again has to do with cardiac muscle cells. But this raises lower and it leaves the blood sooner. So it's a good indicator if we catch it like right now of what's going on with the heart cells when they're damaged, but it's not as good as a troponin. And if we're really good and the person comes in as soon as they feel a twinge in their heart within the first 24 hours, we can check a myoglobin, right? But not everybody comes in the first 20 minutes of their heart hurting and we see it, right? A lot of times we'll see it a little ways out. So troponin, CPK, CKMB, myoglobin, those are the labs when we talk about a cardiac panel, talk about cardiac markers, serial heart enzymes, cardiac enzymes, that's what we're looking at. Okay, so troponin, since it's the one with the little asterisk, right, we know that one's really important. So anything that's positive, like it's being pregnant on the stick, if it's pink at all, it means it's positive. Anything positive tells us there was damage, okay? We have to do serial testing, okay? Because here's what it looks like. It goes up. So if you draw the level here and you never draw it again, you don't know whether that's the highest it's gonna go, or if you caught it on its way up, right? Does that make sense? So we have to do more than one at a time to figure out when it peaks and when it drops off. Okay, so we do it as soon as we see them, and then we're gonna repeat it in 3 to 6 hours. So if somebody comes into your ER, they're complaining of chest pain, they're probably gonna be there at least 6 hours because we're gonna draw their levels more than once. Because they might draw it and it's not doing anything, right? And you draw it again 3 to 6 hours later, and here we are, we're just starting up this trend, right? So maybe we're gonna see it go up. Or if we get 2 in a row that haven't changed, and we're pretty sure that nothing's going on, there is not gonna be a peak or wave, okay? So when we keep them in the hospital, we're gonna keep drawing it, because we gotta find out where does it peak and when does it resolve? Yes,
So if you're not having a heart attack, the troponin is gonna be 0.
correct.
Okay.
Yep.
Not like there's a little bit.
You can't be a little bit pregnant. Nope, a little bit positive with the troponin. Okay, does that make sense? Okay, and again, CKMB, it'll show you, but your margin of error is a lot smaller, right? Whereas the troponin, I mean, I've seen people with 16,000 troponins, right? So that tells you the degree of damage, how peaked that gets. So just keep an eye on it. Okay, the other things we're gonna use, and yes, these are multiple colors just because they're pretty, not because it means anything, right? But we can do an ABG. Why is an ABG important in somebody with a heart attack or a myocardial infarction or unstable angina? Oxygenation, right? We've also got some acid built up, right? But from those cardiac cells that are dying, right? That's gonna lead to some acidosis. So ABG is really important. We gotta look at the EKG. We wanna see what's happening in that electrical activity, right? We wanna look at the echocardiogram. We wanna see if that wall is moving. Right, is it pumping like it should? We wanna look at the perfusion, see if there's cold spots, right? See if it's all doing well. And then we obviously wanna do hemodynamic monitoring, right? Blood pressures, some type of invasive central line or arterial line or something like that. Okay? When we talked about EKGs and we talked about how many wires there are, how many are there? 10 wires. Remember, we talked about 10 leads and it gets 12 pictures, right? 12 different things. When we look at it, this is why. We talked about how when you put the leads on, there's your limb leads, right? For your arms and legs, and then you kind of go 1 and 2 and go around the heart. This is why. Because everywhere you put a lead, if you have a heart attack, right, an MI, it's gonna show you where it happened, right? So I'm looking at the inferior part of my heart. I'm looking at the lateral or the sides. Those look totally fine. But where I'm seeing these elevations, do you see them right there? Right? That tells me it's in the anterior portion of the septal. That's why we do a 12 lead. Because if I'm just looking at these, they look fine. But I want to see the whole picture. So that's just why those tie in. This is a really good slide. Okay, I really like this because it goes from the least dangerous to your well-being, all the way to the most dangerous, and it divides it up into categories, okay? So here is our stable angina. Is this part of acute coronary syndrome? No, stable angina is not. That goes under the really chronic, we rest, we give nitroglycerin, they do fine, right? This one's okay. Our EKG looks okay. And our troponin is all right because we're not damaging the heart cell. This is just temporary, okay? Unstable angina, is that part of acute coronary syndrome? Yes, yes, it is. Why? Because we really severely block this. Are we gonna have changes in our EKG? Yes. What does this look like? What's that called? ST depression. So yes, something is happening and you're gonna see that T wave flipped up, or you're gonna have a downward slope. But what is my troponin gonna look like? It's normal. Why is it normal? Because we're not cutting off the blood supply yet, right? We're still, even though it's a tiny bit, teeny tiny, we are not starving that heart muscle. It's thirsty, it's not starving yet. A non-STEMI, is this part of acute coronary syndrome? Yes, a non-STEMI is, and what that means is it is a partial occlusion. Okay, so for this, and if you go back to the other slide, right here, you can see where blood is still getting through, but it's pretty profoundly narrowed. And usually when that happens, it's in a longer portion. It's not in one particular spot. It's the chronic chronic plaque that's built up that kind of chokes the heart. Okay, it's choking its own blood supply. It's not a sudden closing the tap, but it's closing. Okay, does that make sense? The difference between them? Tell me if you don't get it, and we will go back and revisit it, because I really, really need you to understand this. Okay, you get it? 1 to 5. 5 is, yep, quit talking about it. 1 is, I am completely lost. Where are we at?
So,
Okay.
yeah, okay, I'm not gonna maybe ahead, but like if you are in the hospital and they're like STEMI alert or I mean, what would they see on the way, like just the classic heart attack symptoms versus what symptoms, I guess, would you see in non-STEMI to, I guess, like physically?
So non-STEMI, thank you for asking. Non-STEMI, right, is gonna be injury to the heart muscle. You're gonna see that ST depression, right? It's like the unstable angina in that there's some depression difference, but it's choking the heart enough that it's starting to get damaged. That's the main difference between unstable angina and a non-STEMI, right? It is not a sudden change in the conduction system because we're still getting some blood flow, but it's not enough and we're getting elevated.
So that's just the EMS hooking them up in the field. Like, I mean, like what physical symptoms are different, I guess is my question between the
So when you
non-STEMI
get
and
to a
STEMI.
STEMI, and we will talk about this.
Okay.
But what they're seeing, usually when they call a STEMI alert, right, in the hospital or code STEMI or code heart, wherever you work, whatever it is. We're talking symptoms, right? Severe crushing, chest pain, diaphoresis, drop you to your knees. It could be a whole myriad of things, but usually this is like incapacitating, right? And you're going to see these huge tombstones, these huge ST elevations. That's your hallmark of a STEMI, right? That's what makes it a STEMI. Your ST segment, instead of being normal, or instead of being a little depressed or flattened like these two are, you have huge elevations. Okay, and that's telling you that right now, there is a part of the heart that has no blood flow and the conduction is really having a hard time getting through, right? This is brand new. This is happening right this second, and the troponin is going to be elevated. So here, everything's completely normal, right? Here, we can take our nitro, we can rest, and it's going to go back to normal. These two things don't change, right? Our EKG and our troponin. With our unstable, okay, we're going to have no damage to the heart. We're gonna rest, and it might get better, it might not, but it's not gonna last enough time that it's gonna cause damage to the heart muscle, the point that it releases an enzyme. A non-STEMI is going to also have some EKG changes, just like here, but it's gonna be prolonged enough that you're gonna damage the heart cells. Whereas your STEMI is right now, kink in the hose, no blood flow, conduction is really disturbed, and your heart muscle is dying right now, real fast. Okay? Most of the time, when you get these STEMIs, it's gonna be in that left anterior descending, the artery that feeds the left ventricle. And we call that the widowmaker, because if you're having this occlusion, right? And you're having damage done right now to that heart muscle in your left anterior descending, you are not long for this world unless you have intervention. Okay, those are the people that we have the crushing chest pain, they drop, they go into a V-fib, and we've got a code.
Is that the one that you like, you feel you can feel the pain like in your jaw sometimes?
It can, although I really don't like that. I think in movies and TV and stuff, people talk about like their jaw pain.
I had
And
a
they're-
friend that was like, couldn't figure out like why he was having so much pain like up here.
Yeah.
And his heart was fluttering, or I guess would have been this side. And they saved his life, he had a
Yes.
widowmaker, but it,
I had a friend who had a STEMI to her LAD, and her pain was between her shoulder blades. So that's why I said, anything like neck to navel, like if they're having some type of a symptom, check it out. But yes, they can be sweaty, they can be pale, they can have perfusion, they can have low blood pressure, lots of things. But this is a really good way to kind of test your knowledge on one to the other, okay? So the difference between the two, if you had to do a compare and contrast, okay? You've got chest discomfort. You've got, it matches exertion, rest and medicine, some warning signs. With the myocardial infarction, that's the complete block. We do damage the muscle, requires immediate medical attention. Okay, it says intense chest pain, it can be lots of other things, but we're damaging the heart. Okay, so that's the main thing with that, is it's causing damage. If you're looking at a STEMI versus a non-STEMI, I made my own chart. Can you tell this is important to know the difference? Yeah, right, it's not to confuse you, it's just, last year I had a lot of students who were really confused, and I wanna make sure that we're even. So the colors match on both sides. Okay, that colors do mean something on this slide, I promise, okay? So, not enough blood flow, same. Does not change the electroactivity, does change the electrical activity, right? This is where, with these STEMIs, this is where you get your people that code suddenly. They come in for chest pain, they have a STEMI, and they code. My friend who came in with a STEMI and went into VTAC, and we shocked him. It's because it changes the electrical activity, okay? Partial blockage in the artery or a branch off of the artery, right, can cause that non-STEMI. Total blockage is your STEMI. ST depression or the T wave flipped upside down. ST segment going up, sometimes you have something called a Q wave, which is a little extra dip. You don't have to know the specifics, but understand that it causes some changes. This one is not gonna show those big tombstones, right? It's not gonna show those huge MIs. So this is where the testing comes really into play. Look at those troponins. Look and see what they're doing. Look at those CKMBs, see what it's doing. On this one, we see it on the EKG, so it's easier to find. We know that there can be VFib in that first hour of that blockage hitting. We have a real good risk of that. And then when we already are getting it taken care of in the first 4 hours after you have an MI, even if you're not having those huge tombstones anymore, that heart muscle is so irritated, it's gonna start throwing PVCs. And you know what those are now, right? And so it's gonna start throwing those PVCs, and that itself is a risk. Okay, so if you have a question about a patient who just had an MI that's throwing a bunch of PVCs, not good, right? We definitely wanna keep an eye on it. Does this help? Know this one too. Okay. This is a video that I'm not gonna show you because, for sake of time, but if, actually, let's watch that, I'll make it a little better. MIs usually affect the left ventricle because that is where most of the work of the heart happens, okay? So when we have, the heart squeezing on the left side, that is where you obviously need the most oxygen and you need the most, blood supply because it has to squeeze. Where is this? Won't work, we can go back and watch it later. So, just like Emily was talking about, so what does it look like when you are having a heart attack, right? Any of these things, plus whatever else you can find. Okay, so they might have fast heart rate, they might be nauseous, they might just say, I think I'm gonna die, I think I'm gonna die, don't let me die. Right, and when you have somebody who says that, don't just dismiss that, okay? When somebody's super anxious, even if you can't find any other symptom when they come in and they're saying, I feel like I'm gonna die, I just feel like I'm gonna die. Trust me, they sometimes know what's coming. If they are not pumping well, they might look like they have shock, right? They might not have a good pulse, they might have low blood pressure. Conversely, they might have high blood pressure, right? So any and all things related to not your normal baseline can be attributed to a heart attack. Okay, so what do? If somebody comes in and they're having an MI. Okay, we definitely want to make sure we got those antiplatelets. Okay, so we're gonna give them the aspirin, we're gonna give them the Plavix or the Brilinta, or whatever else we have in our arsenal. We might go in and actually do a cardiac cath and squirt some clot dissolver in there, a fibrinolytic. To kind of dissolve the clot, redo the flow. Okay, we might want to give them something to keep them from going into VFib, just in case that heart muscle is really irritated. We might give a beta blocker, right? That will slowly open up the heart, keep the heart rate low. And that's again, gonna keep its demand for oxygen lower, because if I need oxygen and I'm not getting it, I'm getting more damage. If I don't need as much oxygen, then I might be a little bit better off if I'm not getting so much. Does that make sense? Okay, that's the difference. Heparin, we might want to give a blood thinner so that what we get can go through that little narrowed area so that we can reperfuse it. And sometimes we might even need something to help kind of boost the cardiac output if the pump's really not working. Okay, but makes sense, we would want to give something for heart rhythms because we know what happens, right? That conduction system changes with an MI. How many people have heard the mnemonic MONA for heart attacks? Okay, that is super outdated. And actually there's all sorts of literature that says if you have an instructor who tells you to do MONA, withdraw from the program basically, because it's super outdated. There was a campaign in 2014 where they were basically, the American Heart Association and the Journal of Medicine were all saying, quit saying it, right? If we don't want you to use it anymore, right? But there's still some people who you'll see it used. Now, do we still sometimes use these components? Yes. But do we always, and do we give them in this order? Absolutely not. Okay, so first thing we're gonna do is oxygen, right? Obviously, our heart is starved of oxygen. Okay, here's the problem though. Do we always need it? Not really. If they're over 94%, we really don't need oxygen. So if their stats low, but we don't just across the board throw everybody on oxygen right away anymore. Okay, if they're in pain, yes, we still use morphine. Okay. But we don't, as soon as they come in, give them a dose of morphine, because why? Why would we not want to take away all their pain? You can't tell you if it's changing, you can't tell if it's any better or any worse, right? And sometimes lowering your blood pressure and lowering your respiration, your respiratory drive with a narcotic is not the best thing, okay? Nitroglycerin, do we still do that? Yeah, most of the time, except when it's on a certain part of the heart, right? Because there's certain parts of the heart where we don't want to dilate because we need that to be constricted enough to shoot the blood where it needs to be. If you dilate it out, we've now lost all of our blood volume to that heart muscle. So yes, if we give it, maybe sometimes, we definitely don't want to give it if we don't have a good health history, Because we found out when Viagra became super popular, right? Viagra worked because it was made for pulmonary hypertension. It was made to dilate blood vessels of the lung and improve your breathing for people that had pulmonary hypertension. They were also noticing that it helped with erectile dysfunction. So we give it for erectile dysfunction, but also understand that it dilates blood vessels. So if you took Viagra, and very often, I hate to say it, but your most common times of having an MI are first thing in the morning and when you're having sex, right? Because when especially in men, right, they tend to hold their breath during sex. And first thing in the morning, when they've been laying down, they stand up, they get to walk across the room and that sudden change in blood volume, right? But we were finding that men would have crushing chest pain during intercourse after taking Viagra, and we would give them nitro and we would lose them. We would bottom out completely because everything was already dilated from the Viagra, right? And that would cause a problem. So you've got to we don't just throw all this at one person at one time because we got to figure out what we're having. The only thing we do use all the time is aspirin. We always use aspirin because we want that antiplatelet, okay? So we give 4-baby aspirin, or which would be like 325, right? Not enteric coated, we don't want the slow acting stuff. We want you to chew it and swallow it, or we want the kind that acts right now, not the long acting, to work as quickly as possible. Okay, so that doesn't mean we don't use these, but we don't go into every MI with the same motive of like, these are the 4 things everybody gets no matter what. So that's why you're gonna hear this mnemonic, and yes, you need to know what they stand for, but it's not something we use all the time. Does that make sense? Which of these do we use all the time? Aspirin, unless what? Unless they're allergic to it. Yep. Okay, so our treatment goals for our person who comes in with the MI. We want to make sure they feel better. Right, we want to try to get their pain away if we can, as long as it's safe. We want to reduce how much damage is being done. We want to make sure that they have their cardiac output is stable. We want to make sure the heart isn't working any harder than it absolutely needs to, and we want to keep it from getting worse. Okay, so those are our 5 goals for our patients that have an MI. Okay, so what do we do as nurses? What is our role in all of this? We got to watch their vitals. We got to watch them really fast. Like we have to be very diligent on taking our blood pressures and our pulses, on taking those monitor strips and printing them out. Okay, if their sat drops, we need to give them oxygen, but not everybody gets oxygen. Okay, we got to make sure they have IV access, and we make sure that they're not doing anything extra. We want to keep them on bed rest. We don't want them up walking to the bathroom. We're making sure we do careful eyes and nose. And no matter what we do, we are reassessing. We're reassessing for pain. We're assessing for bleeding. We're making sure that we are in constant education with the patient and their family on what's happening, because this is a very anxiety provoking situation. Absolutely. And I can speak to that. When I went to the ER with my husband, he'd been having chest pain that he kind of described as discomfort. He thought it was reflux, right? And he had had it for a couple days. And when he would sit down, it would go away. And he bent over, it hurt. And he actually even went to his primary care doctor, who told him that he needed a strong reflux medication, and told him he could get a stress test. By the time I got our prior authorization, they scheduled him 3 weeks out. Okay, so it kept getting worse and worse. We got to my daughter's choir concert and we were walking across the parking lot. He had to stop halfway across a very small parking lot. And I said, as soon as this concert's over, guess where we're headed? And he said, I know. Right. So we got to the hospital and he walked in and he looked at me and he said, they're going to transfer me, aren't they? I said, yep, you bet they are. Walked in, did the EKG, through the labs, boom, everything happened at once, right? And so I, of course, know more than the average person. I understand what's happening. He doesn't, he's scared. I'm terrified, but also like going into nurse mode, right? And I'm trying to figure out what's going on. And in comes the registration person who walks over to me and says, I need to know how you're paying your copay. And I said, do you need it right now? Well, we can't do anything until you do. So my husband, who's having the heart attack, is like, which card should we use? How much is it? Which one should we, right? What I wanted to say was, go away, right? You can bill me later. And the nurse looked at her and said, do you think now is the right time? And she tactfully kicked her out of the room, right? But sometimes that's what we need to do. We need to be the calm in the storm that says, look, I know you're overwhelmed. This is what's going on. Break it down nice and slow. Anything extra stress wise, it can wait, right? Until we get this stabilized. So make sure that you are communicating very well, because this is really scary. Okay? So if you are getting a patient who you think might have an MI because they have a history of angina, which of the findings would let you know which one is an anginal attack and which one is an MI? People don't know how to play the thumbs up game, or they really don't know the answer. Okay, A, who picked A? Okay, so it can be relieved with rest and nitro. We know that myocardial infarction pain is longer than 30 minutes. That really nothing is gonna cause it. A lot of times it happens during certain activities, but nothing actually causes it. It can even happen when you're sitting down. And we know anginal pain usually is 15 minutes or less. Okay, how'd you do on that one? Very good. Okay. You're reviewing lab results on somebody who had a myocardial infarction. Which lab would still be in place in their blood and confirm it happened 14 days later? Okay, that should be pretty easy, hopefully. Troponin, right? So that's why we use it as our indicator. And do we take it once? No, we take it first time, then how long after? 3 to 6 hours, yep. And after that, if it still went up, we take again? Yep, until we see what? It peaks and starts to drop. Absolutely. A client's asking why they have to take their aspirin. Right? What's our answer to them on why they take the aspirin? We want to make sure that they understand that it can reduce that platelet aggregation. Okay, we don't give it for chest pain. Now, when you go in to give your aspirin to a patient at Ohio Health or UH, and you go to give your aspirin, it might populate with that PRN, like what's their pain level? And that's because aspirin is usually put in for PRN as well. So if you're giving it for cardiac reasons, just skip that PRN, knowing that you're giving it for the antiplatelet property, not for the pain relief property. Does that make sense? Okay. Ready for a break? Take a 5-minute break. Stand up and stretch break. All right, here's our last section. And this is talking about what we do when we find something that is a blockage. How do we fix it, right? That's what this last section is on. We call that revascularization. Like we're re-perfusing what has been blocked. We're restoring the blood flow and oxygen. Okay, so we're going to start with the non-surgical options first. Okay, so angioplasty, right? Same thing as a cardiac cath. They use the same site. So when they go in, when they put the wire up to the heart, they see the blockage. They can actually put in a balloon and inflate it, and it kind of pushes that plaque back and restores blood flow. Okay. They can go in with a little like rotor tool, and they can actually remove the plaque, right? And they can actually go in and do a stent also. All right. These can all be done through the same site. They can all be done through the groin or through the radial, just like a cardiac cath. And a lot of times they'll do it all at the same time, right? They do diagnostic caths, and then they do diagnostic and interventional caths. So they can reperfuse while they're there. Okay. I want to show you this video, just to show you, why is this? I just want to show you what it looks like when it's reperfused. Sorry, I had all these opened and then I closed them and I don't know why. Not prepared. This wants to use. And I wanted to use. So if you watch this video all the way through, it shows you what a cap does and what it looks like. But I want to show you a before and after when they use the stent, right?
And this is the left anterior descending artery, and this is the catheter that is inserted inside the coronary artery, and we see here the left anterior descending artery, and there is significant narrowing in the mid portion of.
Okay, can you see where that's really narrowed? Okay, so right where he's pointing, you can see right in there where it goes from this size to this size. Okay, so that would be where you have greater than 70% occlusion that's causing the blockage and probably causing the symptoms, right?
Significant narrowing in the mid portion of the left anterior descending artery and the first diagonal branch. And this is the wires that they are inserted inside the coronaries. This is the stent that is inserted inside the coronaries. And this is before we deploy the stent. This is the stent that's deployed now. And this is the balloon that's inside the stent. And this is the final image after the stent deployment, where we can see here how the lumen of the artery is completely enlarged and equal to the same lumen of the arteries. Definitely there is more blood flow here and there's better circulation to the.
So if you look at where it started,
And equal.
okay, you can see right here, look how much more blood flow there is to both of those, and you can see all these little baby blood vessels that come off of that artery. Those are the tiny ones that we're talking about. When we talk about how it doesn't necessarily have to be one of the main arteries, it can be for a non-STEMI, it can be a blockage on one of those side ones. Okay. So when they put the stent in, they float it in, just like through the cardiac cath. It's a little metal spring that goes around the balloon. They inflate the balloon, which deploys the stent, and then they pull the balloon back out, okay? So they leave that in there, and then, over time, it will continue to expand a little bit until the blood flow is back where it needs to be, okay? So you can see here it's expanded, and then especially if you're gonna inject a little bit of like a clot blister, the thrombolytic, a fibrolytic, and as that eats away at the clot that's attached to that flap, it'll actually open up a little bit. Okay, so sometimes stents are super easy to put in. Sometimes where the blockage is, they can't quite make the curve to put the stent in. And so that kind of determines when they do the cardiac cath, if they find a blockage, sometimes they're not able to fix it because of just where the location is. But we definitely want to make sure that if they have an iodine allergy, you saw them inject the dye where they could see the perfusion. Yep.
So I actually got to watch a couple of these yesterday in clinical, and the one, he had really significant disease, but the rad tech that was in there doing like the fluoroscopy, he said that the artery was too diffuse. That's the word he used. What does that mean?
So that means instead of it being a clot in one spot, it should be like the area is so long
Yeah.
that they can't fix it with a stent.
Yeah, so he said he was gonna have to go for surgery, so
Yep.
bypass them? Okay.
Because if it's one kink in a hose, you can kind of like open it back up. If the whole artery is narrowed and gross and full of gunk, then it's not gonna do any good over one portion, right? Because you have to line the stents up back to back to back, and it's not worth it, right? It won't work as well. Anytime you do anything with the heart, with stents or cath, make sure that you have resuscitation stuff there, because you never know, okay? Also, they may have chest pain during the procedure. They can get reperfusion pain as well. So make sure if they're having chest pain, you are doing, you're monitoring, you have EKG, you let somebody know. Because it could be something that is minor, it's reperfusion, or it could be during this process, a piece of plaque broke off and now they have a blockage somewhere else. So just kind of keep that in mind. Obviously assess for bleeding wherever the site is, either in the radial artery or the femoral artery. And then afterwards, remember, as the blood goes back to that heart that's damaged, that muscle may be really irritated. Okay, and so really do need to watch that monitoring. Make sure that they're not throwing PVCs, they're not at risk of anything. Okay, check the pulses below the site, right? If it's the groin, you're doing pedal pulses, right? If it's the radial artery, we're gonna make sure that they've got good cavity fill in their fingers. But anything downstream of where we punctured an artery, we gotta make sure we're good. Okay, and then lots and lots of teaching. There's actually a care plan, a little blurb in your book. It's like a 2-page thing on how to take care for a client after they get their cardiac cath. I suggest you read that because it gives a lot more finer points than what I'm pointing out. In the process of trying to make things better and put oxygen back to the heart muscle, we do have a risk of things going wrong. Okay, so we, just like when you fill out your consent form, we have to say like, it could cause anything, including death. We gotta remember what it is. Anytime we're poking in hearts, right, we have a risk. So bleeding risk, blood clot risk, some type of a bleed, right? If they poke something as they're floating in that wire, they could end up with cardiac tamponade if they accidentally pierce the pericardium. So lots of different things that could happen. This is an example of collateral circulation, right? When they go in for their cath, so we're looking at a blockage here, right? It's looking downstream. Sometimes the reason why the person has a diseased heart, but they haven't had that massive MI, has to do with collateral flow. And that is why I geek out about the heart a little bit, right? Not only does it have its own pacemaker, not in one spot, but in multiple spots to keep beating, it can actually notice and recognize it's not getting heart and rewire itself and make its own web of blood vessels. So it can do its own little natural bypass and keep flowing, right? So over time, as the heart muscle is pumping and it's realizing I don't have the blood supply that I need, it just grows new blood vessels, which I think is such a cool thing, right? It's very, very adaptable. It's like designed to survive. So when you go in and do a stent, sometimes if that blockage is there, but we have tons of new little baby blood vessels, they'll just leave it. Right? If the heart has already adapted to go around that blockage, they'll just leave it. They don't want to disrupt it because then you would deprive this side of blood. That makes sense? So collateral circulation is really super cool, I think. The next thing we're going to talk about is the surgical option for revascularization, which is your CABG, your coronary artery bypass graft. Okay. And for that, we use a vein or an artery. And what you're talking about, if you have a vessel that's got clogs all along it, instead of trying to deal with a spot, they will actually just reroute the blood to kind of get away from that and feed the muscle in another spot. Okay, so it doesn't actually change the fact that you have the atherosclerosis in that vein. You don't take it out, you don't take that artery out, but it allows the blood to kind of bypass it. It's if they have an EF, right? Ejection fraction. You get it. What do we want it to be? 50 to 70. We want to make sure it's at least 50, right? Because we want to make sure that it's healthy enough to receive the graft. Okay, if that heart muscle is too weak, it's not going to be able to accept it. Most of the time we do it when they have more than one vessel involved, right? And we can go all the way up to a quintuple bypass, right, over the 5 main arteries. And if at all possible, we use the mammary arteries. And then if that doesn't work, then we go to the saphenous vein. Okay, so you have arteries. So at the top of your heart, right, you have your atrium, you have your ventricle at the bottom. So when your left ventricle branches out to the body, there's actually two arteries that go back down, right? So what we do is instead of these going back down and going out to your chest, we leave them plugged into the aorta. We cut them when they go into your chest and we reroute them to the heart. We like this because these are very good arteries. They're designed to be arteries. We only have to attach one spot. This is a natural bifurcation. That's how it's supposed to go. We just reroute it. Okay? If for some reason we can't access those, then we go to the saphenous vein in the leg, right? And we attach that. But that's not always our go-to option, because if you're a diabetic, right, there's a good chance that your peripheral veins are not in fantastic shape. Also, you have anastomosis at two spots, means you have to like stitch it in two places, instead of here, you're just stitching in one. Okay, whereas this, again, it's got that natural bifurcation, you only have to stitch it in one place. Okay, my husband and my mother-in-law both had open heart surgery within about 6 months of each other. They both recovered at my house. It's a really great time for me, and I had my gallbladder out because all of the stress from this gave me gallbladder attacks. It was a great summer, but when my husband had it done, they did both of his mammary arteries, right? So they, unfortunately, if you're young, think of the amount of chest muscle you have in here, right? They really have to dig in and go through, and his recovery was really painful. Like turning his neck was super, super uncomfortable for him. He was in a lot of pain. They did do each one of those, and they took one from his leg, right? So my mother-in-law came to me. She is almost 80. She had her bypass, right? They did not use her mammary arteries because of the condition of where she was at. And so they used her leg. She's pulling her hair back and doing it. And she's turning her head, doing all these things because they didn't go through the chest wall. So the recovery is going to look different depending on where they do the harvesting. Okay. There are 3 videos on here. I highly recommend this one here with the asterisk, which shows how they use the bypass pump. There's a picture of it in your book, but this gives a really good animation of how they take it out. So what they do is they insert tubes into your atrium and your ventricle. And so basically your heart is still, right? For all intents and purposes, your heart is not beating, right? But what it does is that then it kind of sucks it out of the atrium, the right atrium, puts it through a machine where it oxygenates the blood and, warms it, and then it goes back in the other side. It is pumped into the aorta. So literally your heart is not beating while they do the surgery. Okay. There are new ones that do allow you to do surgery without the bypass. It looks like a metal prong almost. It has a flat spot, and they kind of deploy it on the heart. So the rest of the heart beats, but it just holds this one section still. So depending on the extent of the disease, they can do it that way. I have not heard of or seen it done anywhere locally. So if you hear of it, please tell me, because I'd like to know. But usually they use the bypass. I will tell you though, there is something that they call pump head, that when people are recovering from the bypass surgery, one of the complaints that all of the patients have is short-term memory loss, almost like dementia for a little bit, and loss of executive functioning, because as it's pumped out to that bypass machine, there's micro clots that are formed. And so as it's pumped back in, even though it's safe, right, and it does its job of circulating, there are micro clots that can cause some either temporary or unfortunately some permanent loss of functioning, mental capacity wise, right? So I noticed that a whole lot. My husband, when he got cleared to drive, I didn't let him drive very far at all, because we would drop off the kids and he'd say, "Where are the kids?" as we pulled out of the driveway. Or we would like be headed somewhere and he'd forget which way to go somewhere. He does a lot of architectural type thing using CAD or whatever. And we were trying to follow his plan to build something at the high school. And we finally just took it away from him and did it ourselves because he was having us change things 3 or 4 times because he couldn't read his own drawing. He couldn't spatially take care of it. It was temporary. It did not last very long, but they call it pump head because a lot of people experience that. It's fogginess, trouble thinking, and short-term memory because of the pump. So if your family is starting to be concerned about it, assure them that that is not anything uncommon. Okay, so when they do open heart surgery, they go through the middle, they do a sternotomy, they use the bypass pump, and they do induce hypothermia, right? That decreases that metabolic rate and decreases the demand of oxygen for the body. And that makes sense if we're trying to bypass it, we want to deliver oxygen, we want as easy of a time as we can. They will have epicardial pacing. Remember we talked about that, the little pacing wires that have the little barbs on the end that attach to the heart, and those will come out. They'll be external, they go to a pacer box. So when your patient comes back from open heart, they will have that pacemaker box and they will have chest tubes, right? So once you open up that chest cavity and you wire it back shut, you have to reestablish that negative pleural space. So they will have, usually they have 4 chest tubes. Okay, so just be aware of that. Again, educating the family, what it's gonna look like, what it's gonna feel like. Here's a tour of the unit. Here are the different things you're gonna see, right? Because there's a lot going on, especially that first 24 hours after they have surgery, okay? Let the family know, let the patient know what to expect, right? They come back on a ventilator, so we might have to, wean them off the vent, right? They're gonna have lots of monitoring. They're gonna have a swan line, they're gonna have an arterial line. Maybe they'll be on a balloon pump, right? These are things that we'll talk about going forward, but they're all different things we do to try to help the heart function as well as it can while it's recovering. But we do want them up and moving. Like in the first day, they're gonna be up and out of bed to the chair, and they want them walking. They want them walking 3 times that first day. Okay, so it's not like, oh, we have to let them sit and recover and, they're gonna be on bed rest for a long time. They want them up and moving because they want to keep that heart going, decrease the risk of blood clots. Okay, so when you're caring for these clients, not only are we doing the other things, which is frequent assessment, intake and output, watching the monitor, watching their blood pressure, but we also are gonna watch the chest tube drainage, right? We're gonna make sure their pain is under control. We're gonna make sure that they don't spike a fever. Okay, because we've just opened up the heart, right? So we've got lots of microbes that could be in there. So we want to make sure we're looking. After they go home, it's going to be a whole lot of education on what to do, right? This is held together with essentially some wire until it calcifies over. Okay, so simple things. You're not riding in a car where there's an airbag that might hit it. It's what happens if that airbag goes off. Right? You don't even have a solid bone, okay? Nothing that is twisting, nothing that's lifting, anything that would twist this. Okay, there was a patient that we had that had open heart surgery, and at about 4 weeks out, he thought he was feeling pretty good, and he was helping use the log splitter and was doing this all day, and he dislodged his wires and had to go back and have open heart again because the wires had shifted enough that it wasn't lined up. So we want to make sure that we don't scare them, but we let them know. Okay. A question that you often get, especially in your clients that are a little bit more younger, will say, when is it safe to resume all my activities, including sexual activity? And usually they'll say when you can go up 1 or 2 flights of stairs without being, winded or anything, you can do that. My husband ran upstairs real fast. My mother-in-law took her a long time. She didn't care upstairs. So this is one of the different devices that they might go home with. They call it a heart cover. They might also have a pillow, and we need to teach them to splint, right? When they cough and they deep breathe, that's super important, but they're going to be hesitant because all those ribs, think of all those muscles that you have in your chest, right? So by squeezing the heart cover, like it applies equal pressure, or they hug a pillow, squeeze a blanket to their chest. That way they can get up and down. They can still deep breathe, but they hold everything together. So here's a picture of a recovered open heart, and you can see these spots right here. Those are from the chest tubes. So those are where they get pulled in there, okay? So they'll have chest tubes coming out the bottom, and then usually the pacing wires kind of come out in this spot area. And so as they recover, everything gets pulled and removed. Okay. So some practice questions on this part. Okay, this is another one. What makes you suspect? Gravity. Okay, ST elevation, right? That's what we call a STEMI. Good. Why do we put them in hypothermic protocol? We want to decrease our metabolic rate, and we want to decrease our O2 demand, right? Hypothermia, we still keep the heart moving unless it's on bypass. That word anastomosis, again, that's where they stitch the new graft onto the heart muscle. And it actually will suppress inflammation as well. Okay. Caring for somebody 4 hours out from surgery. How many people pick A? B? C? D? Okay, these are, you'll see a couple of questions that are similar to this style on your quiz, and you'll see them on the test, okay? So what is gonna be your best option? Anybody who picked D, telling them that he has to do it, you must do it if you want to avoid something, not our best therapeutic communication, right? Explaining to them, encouraging them, educating them, those are words that we want to use, but telling that they must, anything that has those type of wording in it is not gonna be our best option for therapeutic communication. Even if it's right, that's probably not our best option. Okay, so our best option is gonna be B. Because we wanna do something to make it better, right? So we'll give our IV, right, and it says administer an IV pain medication. So this pain medicine work when an IV is in 15 minutes usually? Yeah, so that'd be decent. Come back and see if we can do it. Okay, telling them that we're just gonna forget it and we'll come back in an hour without doing any intervention is not a good option, right? Because in an hour, he's gonna say, I don't feel like it then either. Okay, for our incentive spirometry, we want to make sure that we are at least 500, right? 750 is even better, but 200 is not gonna prevent atelectasis. 200 is pretty minimal. And like I said, not a bad thing to remind them what happens if they don't do it, but that's not the best approach. Okay.